Good morning. I'm Sommer Wedlock. I'm the Vice President of the Gairdner Foundation. Honored to be here today. This is my 5th year in a row attending the CUGH, so my congratulations to Keith Martin and the entire team for another incredible weekend. I will ask for my slides. Perfect, thank you. So for those of you who aren't familiar with the Gairdner Foundation, we have 3 main missions. The first is to celebrate and recognize excellence, and we do this through our Canada Gairdner Awards. So we have 3 types of awards. There's our Canada Gairdner International Award, which is for biomedical research. There's our Whiteman Award, which is specific to a Canadian, and we also have a Global Health Award. Our second mission is to convene leaders, and we do this through hosting research symposia, public lectures across Canada. And lastly, we attempt to inspire the next generation to consider pursuing a career in research. And we do this by bringing our laureates to Canada. They speak with high school students across the country in hopes that will inspire them to pursue a career in STEM. The John Dirks Canada Gairdner Global Health Award is given annually, and it started in 2009. It is now named in honor of our President Emeritus, Dr. John Dirks, who is critical in its development. You will see here we have a pretty impressive group of laureates. We've recognized contributions in the area of HIV/AIDS, Ebola, and many more. On this list is Professor Satoshi Omura. He subsequently went on to win the Nobel Prize. He is the 87th Gairdner to go on to win the Nobel, so our odds are about 1 in 4 now. So receiving the call that you've won the Gairdner has become exciting for more than one reason. The prestige of our awards really depends on the rigor and the excellence of our adjudication process. On the slide, you'll see our 11 international global health leaders who help us choose the winners, and some of them are with us here today. The Gairdner Foundation has been honored to partner with CUGH, and as many of you remember, last year we featured Dr. Cesar Victoria. Unfortunately, this year our announcement of the 2018 laureates does not take place until March 27th. So today you'll hear from some past laureates and committee members instead, but I do invite you to tune in to our live webcast on March 27th, where you can learn the news of this year's laureates. We do accept nominations worldwide, so I hope that you'll consider nominating someone. Nominations open next month, and the deadline is October 1st. So as I said, today it'll be a panel discussion, and we're looking at global health priorities. As a proud partner of the Canadian government, Gairdner's focus on global health issues is an important part of the Canadian ecosystem in support of global health. The Trudeau government is promoting a feminist international assistance policy that puts women and girls at the heart of global health priorities, as well as at home in our Indigenous communities. A focus on reproductive health and reduction in maternal and infant mortality is seen as a key to overall health improvement and economic growth. Canada also recognizes the importance of research in reaching these goals and funds global health research through IDRC, Grand Challenges Canada, and CIHR. Although the goals are noble, the financial support may not match the rhetoric, as recently outlined in the Lancet special issue on Canada's global role in health. And now, it is my pleasure to introduce an individual who needs absolutely no introduction after this morning. Dr. Roger Glass is a member of our Global Health Adjudication Committee, and I'd like you to help me join in welcoming Roger to the stage.
Okay, great. Delighted to be here. Let me get my panelists up on the stage. King Holmes coming forward here. King, you all know, the 2013 recipient of the John Dirks Award. Can I help you, Rose? Welcome. King. Roger, welcome. Srinath, how nice. Okay. So let me begin with King Holmes, 2013 recipient of the John Dirks Award for his global scientific contributions to the field of sexually transmitted diseases and their effective treatment and prevention. He's been a pioneer in what was markedly overlooked field. His application of epidemiologic, clinical, laboratory, and behavioral science produced a revolution in the understanding and treatment of STDs. Throughout his time working in Africa, Latin America, Southeast Asia, and Western Pacific, King Holmes had become a leader of and a significant mentor to subsequent generations of researchers in the field. Currently, King serves as the Director of Research and Faculty Development at the University of Washington's Department of Global Health and the Director of the Center for AIDS Research and Professor in the University of Washington's Department of Medicine. King, welcome, and let's give him a round of applause. Thank you. Sitting next to King is Dr. Rose Leke, Emeritus Professor of Immunology and Parasitology at the Faculty of Medicine and Biomedical Sciences at the University of Yaoundé in Cameroon. She served on the adjudication committee responsible for selecting the annual John Dirks Gairdner Award, Health Awardee since 2016. She has an extensive career in malaria research with a focus on the effects on pregnant women. She's also been a leader in her field in Cameroon and in the international community as a director and advisor for many international initiatives addressing malaria treatment and prevention, polio and health research as well. Rose is a strong and active proponent for women in science and a recipient of the Kwame Nkrumah Scientific Award for Women. Welcome, Rose Leke. And last, Dr. Srinath Reddy, President of the Public Health Foundation of India and formerly the head of the Department of Cardiology at the All India Institute of Medical Sciences. He's been a member of the Canada Gairdner Committee since 2014. Srinath is a world leader in preventive cardiology. He has made vital contributions to the committee through his knowledge of non-communicable diseases, preventive medicine, including tobacco control, and cardiovascular health promotion, and public health. He's a long-standing leader in India and across the global health community and has served on many advisory and leadership roles. Currently, he's a member of the Leadership Council of the Sustainable Development Solutions Network and chair of its thematic working group on health. So there is our panel. And let me begin by moderating a few questions to this panel. Can I do that thing now? Okay, you all have a microphone. Okay. So with that, King, let me start with you and let you provide an overview for a few minutes of your own research. About 3 minutes each we'll have from each panelist, and then we'll open it up to questions.
Well, thank you very much, Roger, and it's a pleasure to be here. We were asked today first to talk about what did we do that led to the Gairdner Award in the past and discuss our own research in that sense. And the Gairdner Award I received was for research done with my global health mentees and trainees. And I wanted to show a slide. I don't know if it's, yeah, there they are. And that was this was a gift from Tom Quinn about 15 or 20 years ago. And it shows the people who I had the good fortune of having either as mentors or as mentees. And I had started my own work on research when I was drafted by the Navy. That was about 54 years ago. And they were kind enough to assign me to Hawaii after they threatened me with Barstow, California, I have to say. And it was to work on curing sexually transmitted diseases that was incurable on aircraft carriers. So that was how I got started. And I show this slide because it really shows that these are the people who did the research that the Gairdner Award was recognizing, much more than me. And they have gone on, many of them, to be here today doing their own research. Many have had as many trainees as I'm showing you on this slide for what it looked like for me about 15, 20 years ago. And I think that the impact of my research is really through these young individuals then who have developed their own list of trainees that's at least as big as this one and really represents a large number of people. So what did they actually do? The others who might be on this list included Peter Piat and Elizabeth Bakusi, and I was able to use the Gairdner funding to donate it to the University of Washington. And it was used to bring to the University of Washington several of these former trainees for stays of 2 to 3 months, to a recent award that was given to Ruanne Barnabas as a professorship. And Ruanne will be, I think, funded by this for about 3 years. And she came from South America, got a Rhodes Scholarship, went to Oxford, and now is with us. So I will just stop by saying that the Gairdner Award has had an enormous impact on me, but on our university as well, by bringing back many of these people and some new people to expand their own research. So I'm very indebted to them. Thank you.
Great, thanks very much, King. Amazing career, and congratulations on that award. Rose, you've been a leader of women's research in Africa and a leader in malaria. Tell us about your career.
Yeah, briefly, I think today we're talking about health disparities. And I just want to talk about one group that need maybe more help than we have looked at, and that is malaria during pregnancy. I have some slides that are showing up there. That when a young woman is growing in an endemic area, you know, she has partial immunity that she develops to malaria. But when she becomes pregnant, she's more susceptible to malaria than she was when she was not pregnant. And this susceptibility leads to, I think I should change the slide as I go on. It's deleterious for, you know, the baby that's growing as well as the mother. The mother, you have the consequences that she can have anemia. It can even lead to death at delivery. But then the babies really suffer from, mothers can suffer from spontaneous abortions, premature deliveries because of intrauterine growth retardation, and so you have low birth weight. So these infants really are exposed to malaria also, more likely, increasingly, when they're born. And what happens, why is this happening? It's just because the mother comes on with an organ that is called the placenta, which at home we call the seat of the baby, but that the malaria parasite also likes as its own seat. So malaria parasites have receptors that bind to, that virtuously bind to chondroitin sulfate in the placenta, and they sequestrate in the placenta. And we, in the early days, when we were doing microscopy, were able to show, we looked at about 1,000 women at delivery. You find out that you find about 25% of them are showing parasites in the placenta tissue, but none in the peripheral blood. So that was kind of, it had to lead to some kind of research translation for how malaria in diagnosis had to be made now and women treated. So we've continued on with this research, and we're going on now. We've done some series of longitudinal studies looking at women through pregnancy, looking at them at delivery, looking at the children also at, for up to a year and later on. And you can see the consequences of what's happening in the placenta, the parasites. When the antigens get to the children are able to produce antibodies right at 26 weeks of gestation. So it means an immune response is taking place. And this also has an effect later on the children, on their susceptibility to malaria. So.
What an amazing story, Rose, and nice contribution to science and to the improvement of child health. Srinath, welcome from India. You must have just come in, and thank you for joining us this morning. Give us a few minutes on your career in global health.
Thank you, Roger. I started off with my career in cardiology with training in epidemiology subsequently. And my research interest at the beginning of my career was in rheumatic heart disease, which at that time was the dominant cardiac challenge for people in India, particularly affecting the poor.
Louder?
Louder? Okay. Subsequently, the research focused on tracking the evolution of cardiovascular disease and non-communicable diseases in India as a part of the epidemiological and health transition, as coronary heart disease and stroke grew much more dominant, and looking at the risk factors and comparing rural to urban to migrant Indian populations and looking at the transition and the interplay of ethnic susceptibility with environmental interactions. And of course, looking at also what came to be known as the Barker hypothesis of early developmental origins in terms of fetal undernutrition and early child undernutrition with rebound adiposity in later childhood on cardiovascular disease. But I think the whole area of intervention in order to reduce the impact of some of these factors became much more important. And therefore, school-based interventions as well as worksite interventions followed in cluster randomized trials. But tobacco control became the very dominant area for research, policy, and advocacy linkages. And there we had a lot of work done on not only the prevalence of tobacco consumption, but also the determinants of that, especially of marketing and entertainment industry on the behavior of adolescents. And much of what we have produced, whether in tobacco economics or in terms of the determinants of tobacco marketing, have led to a very strong tobacco control legislation in India. And finally, now we are trying to position non-communicable diseases as well, but all other areas in the framework of health systems. And therefore, health systems and health policy research has become an area, particularly in the context of universal health coverage. Because we recognize, and that's the philosophy of our foundation, that you cannot rest with knowledge. Knowledge has to be translated into action. Action has to translate into impact, but impact with equity.
Okay. Well, listen, since we have on the panel Srinath, who's been working in the chronic disease area, and Rose and King, who are working in the infectious disease area, the first question I want to raise to the panel is, can you see a tipping point for global health where chronic concerns, chronic disease concerns, and quality of life are the main focus over the infectious and parasitic diseases? How do you address those in the global health arena? Is there a tipping point? Rose?
Well, chronic diseases, as we know today, are major cause of death and disability. It's worldwide. It's not only, in areas, it's worldwide. And we have most infection diseases also, as we know them today. Chronic diseases, remember, we can also have the infectious origins. You have cervical cancer, you have liver, which is hepatitis B, so you can have that. Most of these global initiatives today, of course, they are putting in the money for HIV/AIDS and malaria and immunization and all those. Well, so to say there's a tipping, I would opt to say yes and no. Yes, in the fact that if you are working with in low and middle income countries where you have all these infectious diseases, you can decrease mortality to infection, really decrease it well, where chronic infections are also coming up. And then all these initiatives that are going up are able really to get to a point where they successfully implement their set objectives and they can get rid of all these diseases. Then, of course, you can say, okay, now we turn over to chronic diseases. But no, what's going on? The control of these infectious diseases has proven to be very difficult. We know what we're going through to control them. It's going in, and then the emerging ones are coming on. If not, talk of Liberia, we just heard about Ebola. There's Lassa in Nigeria, you won't hear that. Even the flu here in the US, you see them coming up. So to me, we cannot say tipping point. We have to maybe say both, put in enough resources for the chronic diseases, enough also for the infectious diseases. We should be doing both. That's how I will conclude.
Great, thank you. Srinath, do you want to respond to that? Are we at a tipping point in India to spend more time and effort on the chronic diseases than on the infectious diseases? Where do you sit on that?
Well, given the rising burden of non-communicable diseases and the preceding neglect of policymakers and health systems to address that, this certainly will demand higher attention and priority. But it would be incorrect to think that we have closed the book on infectious diseases. We still have huge challenge of tuberculosis and drug-resistant tuberculosis. We have, of course, the challenge of malaria as well, and rapidly emerging zoonotic infections. So I think we need to focus attention on both and then build robust health systems which actually can address all of these. I believe that even as epidemiological transition will bring forth greater chronic disease burdens, we will have to continue to focus some attention and have some amount of resources on infectious disease control. And in India, this is certainly a joint agenda.
King, you were the first director of a Center for Global Health at the University of Washington. Where does the University of Washington sit on this?
Where do we sit on this? Well, I think that we are leaning towards increasing emphasis on chronic diseases as we are recruiting new faculty to come in, because we have so many who are working in the area of infectious diseases. But at the same time, I think when you look at how other people are ranking, how much priority should we give to the infectious diseases or to the chronic diseases, a good example was the National Academy of Sciences, Engineering, and Medicine. I'll be quick, Roger. I see you're looking at your watch there. But they said we should be ranking international emergency response coordination of epidemics and antimicrobial resistance as numbers 1 and 2, with AIDS, TB, and malaria as numbers 4, 5, and 6. And then they went into the chronic diseases. So that's one assessment, and that was a lot more people weighing in on that than me. We could go on, but I'll turn it back to you.
I'm going to give one or two more questions to the group, and then we're going to open it up to questions from the audience. So prepare your questions after the next question or two. Next question I have is that there's been a dichotomy, if you will, or a back and forth between whether we should be thinking more in investing in implementation research or in basic research. And I think back to the March of Dimes meeting in 1953, when the question came up for the March of Dimes of whether they should invest in vaccines for polio, which had not yet been developed, or drinker respirators. Where do you stand on implementation science versus investments in science and basic research? Rose, do you want to start with that?
Again, I would say both. We have to. Because, the basic science is necessary to get the information that you can now take on and put into the implementation science. Whether you're developing products, whether it's industry, whatever it is, you need that. Then to take it on maybe to the field, to go to the trials, to do your implementation science. So we have to keep doing both. We have to put the resources in both areas.
Srinath?
Well, I believe it's absolutely essential to ensure that whatever technologies that we have already developed are adequately disseminated with impact across the world. And that's where there have been the secondary translational barrier has occurred. And with the technology pileup of even available vaccines not being properly delivered, available drugs not being properly accessible. Therefore, there has to be a great deal of emphasis on utilizing the available technologies to the fullest advantage. As Rose said, that does not mean that we give up our endeavors in basic sciences. But the spirit of human enterprise and the quest for science will automatically give momentum to fresh research in new products. But we cannot afford have a situation where these products are not optimally utilized or adequately accessible to the global population. So the emphasis is at the moment has to be definitely on pushing implementation science.
And King?
Well, picking between implementation science and these other things brings me to want to refer to what's going on now with the studies on disease control priorities 3. We were asked in preparing for this session to list what we thought were the priorities broadly. And I thought that while we're making these quick decisions on what are the priorities, there is a large group of people, hundreds of people working on the disease control priorities 3. There are, I think, versions of this at the UW table for people who want to see it, but it's basically being really thought through in a much more systematic way of what are the priorities that we should be focusing on. And there are now 9 volumes that have been produced by the World Bank with lots of experts weighing in. And those are on display at the University of Washington table. But it's also, it was on the slide I think I put up earlier, you can order this free now from the World Bank. You can get all 9 volumes online. And I would recommend that people go into this in a little bit more depth than a quick answer. They're both important, is my quick answer.
So that's an advertisement for the Disease Control Priority 3 volumes from the University of Washington, free online. Is
Not
that
just from the University of Washington,
but
hundreds of people working on it, but
Okay.
lots from the UW as well.
And the last question from me to the panelists will be, what do you see as the most important advances in global health in the last 10 years? And where would you like to see us when we convene this panel 10 years from now as advances in global health? And maybe we start with you, Srinath, and work over. And then prepare your questions and go to the mics for the open sessions. Srinath.
Okay, from the point of view of the values driving or the motivational factors driving global health, I would say that we have seen global health drawing inspiration not just from a sense of shared vulnerability of epidemics and bioterrorism, but one of shared values, universal health coverage, looking at sustainable development goals in terms of social determinants and environmental determinants. But I think within the area of health itself, the major movement has been towards recognizing the value of health systems. The Millennium Development Goals did not bother about the health systems. They dealt with health conditions and diseases in a fragmented manner. They dealt with life course in a segmented manner: children, pregnant women, no adolescent girls, no elderly, no adults. Now we are seeing all of these converge as important elements to be addressed by a health system with great emphasis on primary health care, that resurgent interest, but tying across all of these elements in a much more unified manner. And the fact that universal health coverage has come forth very clearly in the SDGs is important. And coming back to the values, even as Stephen Lewis said yesterday, the fact that sexual and reproductive health rights made their entry into social determinants and into the SDGs means that our value system has changed from mere reactive response to a sense of shared vulnerability to a much more social solidarity response of shared values.
Great. Lovely response. Rose?
Yes, I completely agree with that. And I would add on to that, in my own perspective, what has happened in the world in the area of these infectious diseases, the idea of elimination, eradication. I mean, smallpox was gone, and today we see what's happening with polio. It's just, you know, there are just 2 countries in the world that have polio. Now we're almost all done with it, and we hope we'll talk about certification very, very, very soon. So we've seen that happen. In 10 years, when we come back, in 10 years from now, we'll say polio is finally gone. We'll see funding going into countries in, like in Africa, really trying to get malaria, HIV, TB down like it never was before with the Global Fund and so on. So you have these initiatives that have come on to try to, you know, see that people there's well-being, there's health in the society as such when people can't afford it. Poverty is still there a lot, but things are kind of improving. There are many areas we could still improve on, but there's been quite a lot that has been done within the last 10 years.
Okay. And King, greatest changes from the last 10 years and where we'll be in 10 years?
Well, 10 years is such a short period of time. I'm talking 50, 55 years. But I think I agree with the points that you guys have made. I think that though we're getting a much better understanding of how we can work effectively with people who have the money and people who are making the decisions on policies than we were before. And that's part of the emergence of global health as a really a leading field that more and more of our leaders, from professors to trainees, are going into. But I think in terms of specifics, we're talking now about policies where we find the information that gets the policy makers to be able to make decisions in our directions, and we're seeing more of that. There's a need for multi-purpose health platforms. We're talking about essential packages of programs that have to be integrated with each other. We're getting much better with childhood vaccinations, as I think you said earlier. And the major infectious diseases are gradually being beaten. You've beaten one of them yourself.
Okay.
So those are some good examples.
Okay, well, with that, let's open it up to questions from the audience. We have about 10 minutes, and I'll start over here, and others go to the other microphones, and introduce yourself and make your questions relatively brief.
Yes, good morning. Ijeoma, Wayne State University, Detroit. Thank you so much to the panelists. In the spirit of debate we just had, I'm interested to know the panelists' perspectives and experiences grappling with the concepts of equity and liberty in your work in terms of eliminating or dismantling disparities in your area of interests. I also just wanted to make a quick PSA, I suppose, that even though I know everybody here is aware that Africa is not a country, that we can be more specific when we are referring to the continent and what specific country that people are from or representing, such as Professor Rose. I didn't know which country she's working in. I'm clear about my other senior colleague from India. It's a country, and so just would encourage us to be more specific. I've heard throughout the conference Africa being thrown around as if it's a country, but specificities to where people are from or working, I think, is helpful in our conversation.
What is the question?
So going back to the question is that I would be interested in knowing the panelists' experience in grappling with the concepts of equity and liberty, just really in reflecting off of the debate we just had in their work as they have worked in eliminating disparities in their respective areas.
So it's a question of equity as we go forward.
And perhaps liberty as well. Just
liberty and equity.
Yeah, if it does feature at all.
And let me take the other question, and then we'll answer them in tandem as others come to the mic. What is your question? Introduce yourself.
Thank you. Dele Ogunshetan, University of California at Irvine. My question was prompted by your question to the panel to think 10 years from now. And 10 years before, we were 1 billion people fewer on the planet, and in 10 years, we'll have another billion people. Most of them will be in sub-Saharan Africa and Asia. And I wanted to ask the panel to think about what is the max capacity that they think we should build for in terms of where this population will be and the kinds of disease burden that we need to be focusing on at that time.
Okay. Equity, the first question. Srinath?
Yesterday, Stephen Lewis mentioned R.H. Tawney, the British economist of the 1930s. In that book, Equality, Tawney mentions very clearly that the concept of equality of opportunity is just decorous drapery if you do not have an equal start. Not just an open road, but an equal start. So the social determinants are determined essentially by the spirit of equity. We have seen, even in countries which are very free and can boast of liberty, that there are huge gaps in health equity and social equity. And we have also seen that liberty quite can have distorted outcomes, like the rise of xenophobic hyper-nationalism in many parts of the world, including Europe. We have also seen concentration of economic power, as our colleague from People's Health Movement has pointed out. So equity has to be the driving element, which will ultimately insist upon liberty as an accompaniment. Without that, you can have liberty with a huge inequality persisting in society. And in India, too, we see manifestations of that, and therefore I would give greater precedence to advocacy for equity and use liberty also as one of the outcomes of that movement.
Srinath, you should have been in the debate. Rose?
I think that part of equity and liberty has been well answered. I just want to answer the man who talked about the population increase as we're seeing, and I think this is a problem that is being handled, at least in our area, in my country. She also wanted to know where I come from. I come from Cameroon. That's it, in Central Africa. I think that was one question. I think we're talking global here, not about Cameroon alone, though my research was in Cameroon. So that we have, the concerns are there, at least in the areas for, the population. You see more, and it really, really increasing. And I think that's something that everybody should be planning for, because it's going to be, more. We need more drugs. You need more vaccines. You need more people talking about equity, also the treatment they get and in health. And so this is a concern that should be taken up by policymakers. And I think we have a duty to try to get the policymakers to work the countries up to thinking about this population increase that is coming on. And we see it all over the world, not only in low and middle income countries.
Okay. And last round of questions.
I want to give one quick answer to
I'm sorry, King.
because it happens in my old hometown. I grew up in Minnesota. This is one of my favorite stories. I was in White Bear Lake, Minnesota, beautiful. Minnesota is the land of 10,000 lakes. There's so much new building now in Minnesota that the governments, local governments, are selling the water in Minnesota to other states, which are even less full of water. So that now we're seeing the houses in Minnesota that used to be worth, that are on the lake, that used to be worth $1 million, are now worth $20,000 because they're sitting on mud pies that go out all, and that's happening all over the state. There may be people here from Minnesota who would argue with you. So we're really seeing the impact of overpopulation in our own country in a lot of places.
Okay. Last round of questions. Oh, okay. Sorry, can't see you down there. Please, excuse me.
Thank you. I really appreciated your question, Dr. Glass. My name is Abbas Alawiya. I'm with USAID's Health Evaluation and Applied Research Development, or HERD, project at URC. And I appreciated your question, Dr. Glass, about implementation science. And I'm wondering, As our project, which is a partnership of 33 institutions that have come together to advance implementation science and global health, has done the work of building this partnership, I get the sense that when we say implementation science, often people mean different things, and when we talk about it in different ways. And I'm wondering how our esteemed panelists would define implementation science and how it's different, for example, from something like impact evaluation or any one of the other ways we assess our work while we're doing it.
Okay, question on implementation science. Let's take the other question down in the far corner.
Hi, my name is Vamshi. I'm a junior doctor from London, but my family is originally from India. My question is, in India, for example, do you think in the past 10 years that really the healthcare has become more equitable? Because my impression is it's still quite pluralistic with a mixture of private and public sector, but do you think the access for people from all different walks of life is better?
I'm sorry, I didn't quite get the question. Just state it again.
Okay. Do you think healthcare in, for example, a country like India is more equitable now than it was 10 years ago?
Okay. Let's take those two questions, and then we'll take the last two here. Srinath, is it more equitable? Is healthcare in India more equitable now than it was 10 years ago?
Certainly, several of the initiatives that have been taken since 2005 have provided greater access, improved quality of primary health care, attention to maternal and child health issues, and have provided some level of financial protection, though incomplete, for hospitalized care. A lot remains still to be done, and there are serious issues in terms of health inequities, but certainly in terms of the health system response, the last 10 years have seen some improvement.
Mm-hmm. And would someone like to give a response to the definition of implementation science and delivery for the representative from USAID? Srinath?
Since I raised the issue of implementation science, I'm ready to respond. I think it's not just impact evaluation and measurement. That is important, of course, of ongoing programs. But I think the whole area of designing innovations after identifying the barriers to effective delivery and evaluating how those interventions are actually improving the delivery of the intended interventions, what their impact on health indicators is, what their impact on health equity is, all of that is implementation science. Understanding the behavior of communities, understanding the behavior of providers, all of that would fall into implementation science. So the entire pathway of effective delivery of available interventions, as well as the design and evaluation of innovations to improve that delivery, will be part of implementation science.
Okay, I hope that answers your question. Let's take the last two questions here before we close the session.
Good morning, and thank you for the panel. My name is Rabi Muhammad Yunusa from University of Washington in Seattle. I like to think I'm from Africa also. My question is about malaria eradication efforts. So, seeing that when malaria was eradicated from developed nations of the world, there was no such thing as malaria vaccine. So now, with billions and billions of dollars gone into development of malaria vaccine, why wasn't that money used instead in implementation, using the same methods that were used before to eradicate malaria? Is my question. So my question really is about research versus implementation. Thank you.
Okay, we'll have a malaria question for the good question. And the last question, please.
Hi, thank you. My name is Carolyn Sun. I'm from Columbia University School of Nursing. And my question kind of follows along with that. So as we talk about health disparities and increasing health equity, my question is, what do you think are important steps that we can take to reduce waste and redundancy in research? Thank you.
Reducing waste and redundancy in research. First, Rose, do you want to address the malaria question?
Yeah, I would say, if you look at malaria today, there are many more countries, since Bill Gates talked about eradication and is putting in quite a lot of funding into it. There's a global malaria program at the World Health Organization now that has even been talking now about malaria elimination And each country, if you go and check in the web, each country, each year, they talk about at least a country. It's true, there are the small islands like Zanzibar and Sri Lanka and so on, that they're trying to really working hard to get malaria out of these countries. And there are a few that are eliminating. You go now to eliminating countries and you will find quite a few. And so what I'm saying is the situation is better today than it was. And more work is going on, more funding is going on. There's even a malaria elimination committee that has just been formed, meaning people will be sitting down now and really making policy about elimination to certification. So there is some hope. There's a lot to be done, but there is hope.
Great. And the last question, Srinath?
Perhaps, Roger, as a research funder, you should be able to answer how to reduce waste and redundancy in research. But certainly I would say that if research is much more focused on problem solving and is evaluated in terms of that impact, then we will be actually having better research in a much more focused manner. But also having said that, transdisciplinary research is absolutely important for achieving that level of impact. And therefore, investment in transdisciplinary research rather than heavy investments in siloed research are going to be very important to have impact on health indicators.
Okay. I see our time is up, so let me ask you to thank the panelists for a lovely presentation and discussions of these events. And thank the Gairdner group for hosting this here. And keep your eyes open for the announcement of the award next week. And perhaps next year at the CUGH, we'll have a coordination of the timing of the Gairdner Award and the Gairdner speaker with the CUGH. Thank you so much to the Gairdner Committee. Meeting adjourned.